The goal to end AIDS as a public health threat by 2030 is a cornerstone of the United Nations Sustainable Development Goals, SDGs, specifically SDG 3, which focuses on ensuring healthy lives and promoting well-being for all. This ambitious target, set in 2016, builds on decades of progress in combating HIV/AIDS through prevention, treatment, and awareness programs. The joint United Nations Programme on HIV/AIDS, UNAIDS, has been at the forefront of this effort, uniting 11 UN organizations and working with global and national partners to achieve zero new HIV infections, zero discrimination, and zero AIDS-related deaths by 2030. However, recent developments, particularly funding cuts initiated by the administration of U.S. President Donald Trump in early 2025, have raised significant concerns about the feasibility of this goal. On June 13, 2025, UNAIDS Executive Director Winnie Byanyima, speaking in Johannesburg, South Africa, warned that the world was already off track with 1.3 million new HIV infections reported in 2023, far exceeding the target of reducing new infections to below 370,000 by 2025. The U.S. funding cuts, which slashed billions of dollars in foreign aid, have exacerbated this setback, threatening to derail decades of progress in the global HIV/AIDS response, particularly in high-burden regions like sub-Saharan Africa. This analysis delves into the context of Byanyama's statement, the implications of the funding cuts, the specific challenges faced by South Africa, which has the world's largest HIV-positive population at 8 million, and the broader global and regional dynamics affecting the fight against HIV/AIDS. It also critically examines the narrative surrounding these cuts, the role of international funding, and the structural and societal barriers that continue to hinder progress, the global HIV/AIDS landscape. Progress and challenges. Historical progress in the fight against HIV/AIDS. The global response to HIV/AIDS has been one of the most remarkable public health achievements of the modern era. Since the epidemic's peak in the 1990s, significant strides have been made in reducing new infections and AIDS-related deaths. According to UNAIDS, new HIV infections globally have decreased by 39% since 2010, and AIDS-related deaths have been halved, from 1.3 million in 2010 to 630,000 in 2023. The expansion of antiretroviral therapy, ART, has been a key driver, with the number of people accessing treatment rising from 7.7 million in 2010 to 29.8 million in 2022. The 95-95-95 targets, set by UNAIDS, have been a critical framework for progress. These targets aim for 95% of people living with HIV to know their status, 95% of those diagnosed to be on treatment, and 95% of those on treatment to achieve viral suppression by 2025. Countries like Botswana, Eswatini, Rwanda, Tanzania, and Zimbabwe have already achieved these targets, demonstrating that with sufficient resources and political will, significant progress is possible. Prevention programs have also contributed to reducing new infections, particularly in Eastern and Southern Africa, where new infections have dropped by 59% since 2010. Among children, new infections have decreased by 58% from 2010 to 2022, largely due to increased access to ART for pregnant and breastfeeding women, which rose from 46% in 2010 to 82% in 2022. Despite these achievements, the global HIV/AIDS response has faced persistent challenges. The 2023 data showing 1.3 million new infections highlights that the world is not on track to meet the 2025 target of reducing new infections to below 370,000. Moreover, AIDS-related deaths, while significantly reduced, remain high at 630,000 in 2023, well above the 2025 target of fewer than 250,000. Regional disparities and vulnerable populations. The HIV/AIDS epidemic is not uniformly distributed. Sub-Saharan Africa accounts for 65% of the 39.9 million people living with HIV globally, with South Africa alone bearing the burden of 8 million cases. Adolescent girls and young women in Sub-Saharan Africa are particularly vulnerable, accounting for 62% of new infections in the region in 2023. Globally, 4,000 young women and girls are infected weekly, with only 42% of high-incidence districts in sub-Saharan Africa covered by dedicated prevention programs. Key populations, including sex workers, men who have sex with men, people who inject drugs, and transgender women, face disproportionate risks due to stigma, discrimination, and criminalization. In 2023, these groups accounted for 55% of new infections globally, up from 45% in 2010, underscoring the need for targeted interventions and legal reforms to protect human rights. Regions like the Middle East and North Africa, Eastern Europe, Central Asia, and Latin America are seeing rising infection rates, with increases of 61%, 49%, and unspecified percentages since 2010, respectively. These trends highlight the uneven progress and the need for region-specific strategies. The impact of U.S. funding cuts under the Trump administration. Background on U.S. funding for HIV/AIDS. The United States has been a major contributor to the global HIV/AIDS response, primarily through the President's Emergency Plan for AIDS Relief, PEPFAR, launched in 2003 under President George W. Bush. PEPFAR has invested over $100 billion in HIV/AIDS programs, saving an estimated 26 million lives, particularly in sub-Saharan Africa. In South Africa, approximately 20% of the HIV/AIDS budget has historically been funded by the U.S., supporting testing, treatment, and prevention programs. However, in January 2025, President Donald Trump announced a pause on foreign aid, including funding for PEPFAR and the U.S. Agency for International Development, USAID, for a 90-day review period. This pause led to the termination of many U.S.-financed HIV/AIDS programs, with stop work orders issued to clinics and research initiatives across Africa. The cuts, finalized in February 2025, have had immediate and far-reaching consequences, particularly in countries heavily reliant on U.S. support. Winnie Byanyama's warning and its implications. On June 13, 2025, Winnie Byanyama, speaking in Johannesburg after meeting South African President Cyril Ramaphosa, highlighted the devastating impact of these cuts. She noted that the global plan to end AIDS by 2030 was already faltering, with 1.3 million new infections in 2023 far exceeding the 2025 target. The funding cuts, she warned, would lead to a further increase in infections and deaths, as prevention and treatment programs face disruptions. Byanyama pointed to immediate effects, including a drop in clinic attendance in several African countries and the closure of community prevention clinics. In South Africa, where 8 million people live with HIV, the loss of U.S. funding has already reduced testing and monitoring services. She estimated that without restored funding, an additional 6 million new infections and 4 million AIDS-related deaths could occur by 2030, reversing decades of progress. The cuts have also disrupted the supply of life-saving antiretroviral drugs, with countries like Nigeria, Kenya, Lesotho, South Sudan, Burkina Faso, Mali, Haiti, and Ukraine at risk of running out. In South Africa, the Treatment Action Campaign, TAC, warned of a potential return to the early 2000s, when access to HIV services was severely limited, leading to widespread suffering and mortality. Specific impacts on research and prevention. The funding cuts have halted dozens of HIV research trials across Africa, including efforts to develop vaccines and new therapies. For instance, Patrick Arbuthnot's work in Johannesburg, part of the US-funded Brilliant Consortium, aimed to develop an HIV vaccine by studying elite controllers who naturally suppressed the virus without treatment. The abrupt cessation of funding in February 2025 forced these trials to pause, potentially delaying breakthroughs that could transform HIV prevention programs, particularly those targeting vulnerable populations like sex workers and men who have sex with men, have also been hit hard. Clinics serving these groups have closed, and health workers have lost jobs, further limiting access to testing and treatment. Byanyama emphasized that before the cuts, prevention programs had reduced new infections, but not at the pace needed to meet global targets. The loss of funding is expected to lead to a sharp rise in infections, though the exact magnitude remains uncertain. A proposed deal, leveraging lenacapavir in response to the crisis, Byanyama. Byanyama proposed a bold strategy to the Trump administration, an amazing deal involving the U.S. company Gilead's HIV prevention drug, lenacapavir, sold as Sunlenca. This injectable, administered twice yearly, has shown near-complete efficacy in preventing HIV infection in women and high efficacy in men. Bayanayama suggested that Trump could enable Gilead to produce and license lenacapavir globally, reaching millions in need while generating profits and jobs for the U.S. economy. She framed this as a win-win opportunity to advance the fight against HIV while aligning with Trump's deal-making approach. However, the feasibility of this proposal remains uncertain, as the U.S. has not indicated a willingness to restore funding or pursue such a deal. European donors, facing their own budget constraints, are unlikely to fill the funding gap, further complicating the global response. South Africa. The epicenter of the HIV/AIDS crisis. The burden of HIV in South Africa. South Africa has the world's largest HIV-positive population, with 8 million people living with the virus. This accounts for roughly one-fifth of the global total and makes the country a critical battleground in the fight against AIDS. The epidemic has deep social, economic, and health implications, disproportionately affecting women, young people, and marginalized communities. The country has made significant progress, with 88% of people living with HIV aware of their status, 89% of those diagnosed on ART, and a high rate of viral suppression. However, challenges persist, including high incidence among adolescent girls and young women, who face systemic inequalities such as gender-based violence and limited access to education and healthcare. Impact of U.S. funding cuts in South Africa. The U.S. has been a major funder of South Africa's HIV/AIDS programs, contributing about 20% of the national HIV budget. The cuts implemented in February 2025 have already led to reduced testing and monitoring services, with clinics reporting lower attendance and closures of community-based prevention programs. The Treatment Action Campaign, TAC, a leading South African advocacy group, has warned that these cuts could reverse gains made over the past 2 decades. In the early 2000s, limited access to ART led to widespread deaths and suffering, a scenario the TAC fears could return without sustained funding. South Africa's reliance on external funding highlights the broader issue of health system fragility. While the country has made efforts to increase domestic funding, the fiscal constraints of a middle-income economy limit its ability to fully compensate for the loss of U.S. aid. Bayanayama noted that even poor, indebted countries are attempting to plug funding gaps, but the scale of the shortfall requires international support. Research and innovation in South Africa. South Africa is a hub for HIV research, with institutions like the University of Cape Town's Institute of Infectious Disease and Molecular Medicine leading efforts to develop vaccines and therapies. The Brilliant Consortium, which includes South African researchers, has been particularly affected by the U.S. funding cuts, halting trials that could yield breakthroughs like an HIV vaccine. The loss of funding also threatens the rollout of innovative treatments like lenacapavir, which could significantly reduce new infections if made widely available. South Africa's research infrastructure and large HIV-positive population make it a critical testing ground for such interventions, but without funding, these opportunities may be lost. Broader implications for the 2030 goal. Funding gaps and global solidarity. The global HIV/AIDS response requires an estimated $29 billion annually to meet the 2030 targets, but funding in 2020 was nearly 30% below this level. The U.S. cuts exacerbate an already significant shortfall, with UNAIDS estimating that an additional 6.3 million deaths and millions of new infections could occur by 2030 if funding is not restored. Bayanayama has called on other wealthy nations to step in, but traditional donors like European countries are redirecting funds to defense and other priorities, making it unlikely they can fill the gap. This fraying of solidarity between and within countries threatens to undermine the global commitment to ending AIDS, human rights and structural barriers beyond funding. Bayanayama and UNAIDS emphasize that protecting human rights is essential to ending AIDS. Stigma, discrimination, and criminalization of key populations, such as gay men, sex workers, and people who inject drugs, create barriers to prevention and treatment services. For example, in countries where same-sex relationships are criminalized, gay men are significantly more likely to be infected with HIV. Progress has been made in some regions, with countries like Botswana, Angola, and Singapore decriminalizing same-sex relationships in recent years. However, 68 countries still maintain such laws, perpetuating stigma and limiting access to care. Gender inequalities also play a critical role, with women and girls in sub-Saharan Africa facing higher risks due to limited access to education, economic opportunities, and protection from gender-based violence. The role of community-led responses. Community-led organizations have been vital to the HIV/AIDS response, providing services, advocacy, and support to marginalized groups. However, these organizations are often underfunded and excluded from decision-making processes. Bayanayama has stressed the need to empower communities and integrate them into national health systems to sustain progress. The closure of community clinics due to U.S. funding cuts has already weakened these networks, reducing access to prevention and treatment for vulnerable populations. Critical examination of the narrative. While Bayanayama's warnings and the reported impacts of the U.S. funding cuts are well documented, it's worth critically examining the narrative. The reliance on U.S. funding, while significant, highlights a broader issue of dependency in global health systems, particularly in Africa. South Africa and other countries have been urged to increase domestic funding, but economic constraints and competing priorities limit their capacity. The framing of Trump's cuts as the primary driver of the setback may oversimplify the issue. The global response was already off track before the cuts, with 1.3 million new infections in 2023 indicating systemic challenges beyond funding. These include inefficiencies in aid delivery, corruption in some health systems, and persistent stigma and discrimination. Bayanayama herself acknowledged valid criticisms of how HIV aid has been delivered, suggesting an opportunity to rethink strategies. Moreover, the emphasis on lenacapavir as a potential game-changer raises questions about pharmaceutical industry dynamics. While the drug shows promise, its high cost and the need for widespread licensing agreements pose challenges, particularly in low-resource settings. The proposal to leverage U.S. economic interests may align with political realities but risks prioritizing corporate profits over equitable access. Pathways forward, strategies to get back on track. Restoring and diversifying funding. To achieve the 2030 goal, global leaders must prioritize fully financing the HIV/AIDS response. This includes restoring U.S. funding through programs like PEPFAR and encouraging other wealthy nations to increase contributions. Innovative financing mechanisms, such as national insurance schemes and regional manufacturing initiatives, could reduce dependency on external aid. The African Medicines Agency, AMA, recently established, offers a pathway to strengthen local production of HIV drugs and diagnostics, enhancing self-reliance. South Africa's potential to lead in this area, given its research infrastructure, should be supported by international partnerships. Scaling up prevention and treatment. Expanding access to prevention tools like lenacapavir and pre-exposure prophylaxis, PrEP, is critical, particularly for high-risk groups. Integrating HIV services with sexual and reproductive health programs and addressing gender-based violence can reduce infections among women and girls. Ensuring universal access to ART remains a priority, as 9.3 million people living with HIV globally are not receiving treatment. Community-led clinics and outreach programs must be revitalized to reach marginalized populations, addressing human rights and inequalities. Decriminalizing same-sex relationships, sex work, and drug use is essential to reduce stigma and improve access to services. Education initiatives, such as the Education Plus initiative in 12 African countries, can empower girls and reduce their vulnerability to HIV. Advocacy.